All right, we can get started. My name is Shivani Ahlawat. I'm a radiologist at Hopkins. I've been there for about 10 years. Most of my practice is musculoskeletal radiology, so anything in the periphery of the body. But because we're a tertiary sarcoma referral center and we have an NF center, a lot of imaging is of peripheral nerve tumors, so schwannomas, neurofibromas, and MPNSTs. So we're going to talk about guidelines and consideration of schwannomatosis, and we'll include the updated new diagnostic criteria and how imaging can help in diagnosis, surveillance, treatment, when to use it, and what questions it still can't answer for people. This is my unrelated disclosure. So we'll talk about the role of imaging in the context of the new diagnostic criteria. And I'll highlight some specific modifications and technique that we do in our institution, and some questions that imaging still can't answer. So why do we have the new diagnostic criteria? Why is it still not NF2 and schwannomatosis? Because there's a lot of overlap between the two. We know more about genetic testing. We also know more about tumor types that are associated and some that are not associated with NF2 and schwannomatosis. So the new diagnostic criteria combines clinical phenotypes. So you have to have clinical feature first with genetic testing. And based on the genetic testing, it can be a gene-related schwannomatosis. So if the NF2 gene is present, you would say NF2-related schwannomatosis. So the NF2, the genes that have been elucidated so far, we have NF2-related schwannomatosis, SMARCB1-related schwannomatosis, LZTR1, 22q, and then schwannomatosis that's not otherwise specified or not yet classified. So now we'll look at a lot of MRIs, and since it's just the two of you, you can ask any question that you want, and I can answer all of them to your heart's content. This is something we do routinely in our practice. These are slices through the brain at the level of the inner ear, so you can see that's the outside part of the ear, and that's the other side. And in this person, we see some tumors. So there's something expanding the internal auditory canal, and it's taking up gadolinium or contrast. And it's on both sides. So this person has bilateral vestibular schwannomas, and that is the clinical feature associated with NF2-related schwannomatosis. So in that person, genetic analysis is not needed. They've met the clinical criteria and they're done. So they have NF2-related schwannomatosis. In our practice, if we have someone that's coming in with NF2 or we're worried about an inner ear tumor, we tend to do thin slice T2-rated images that are less than 3 millimeters and really thin slice post-contrast images. However, if this person did not have thin slice imaging, they still had bilateral vestibular schwannomas, so they would meet the diagnosis. And that's something that's addressed in the new updated diagnostic criteria. MRI has been established as a test for evaluation of inner ear tumors. And when you look at all comers or all different kinds of tumors, vestibular schwannomas are diagnosed with very high accuracy. So this is the test to do. And we do perform it with contrast material, especially if we're trying to evaluate treatment response. So if someone's gotten a medicine, we will measure 2-dimension size or even volumes of these tumors on this particular sequence. What about CT? CT might be an easier test. It's a much faster test. It takes seconds, while MRI might take 30 to 45 minutes. And maybe you would say that I see some expansion of this bone here and there is a tumor here, what do you think? So the only paper that I could find looking at CT for this purpose is from 1977, and if you did a CT without contrast, one would miss about a little more than half of the vestibular schwannomas. And if you gave contrast, we let more people come in than I would start.
I was enjoying it.
It was. No, we can, if you don't mind, we can go back from the beginning.
We all were in the next.
Okay. Hey. I didn't know, so I started at 1, so we had one family. We can start from the beginning now that we have more people, yeah. Okay.
Very good. Very good. Because it is a special honor to actually introduce Dr. Shivani Ahlawat, because she is not only a dear colleague, but also an amazing radiologist from whom I really learned a lot of things over the years. She's an associate professor at Johns Hopkins. She is also director of the Musculoskeletal Imaging Fellowship. She's an expert on high resolution MRI imaging, and she has a particular interest in really advancing the guidelines for imaging in patients with neurofibromatosis. And as such, she's also part of the RAINS group, who is like constantly working those imaging guidelines and practices in order to help us improve care on patients. So thank you so much.
So, it's my pleasure. We'll start from the beginning again, if that's okay. My name is Shivani. I work at Hopkins. I've been there for 10 years, and a good amount of my practice is peripheral nerve tumors. So today we're going to talk about imaging guidelines and considerations in schwannomatosis, and we're going to focus a good bit about on the new updated diagnostic criteria. Come on in. We're just getting started. This is my unrelated disclosure. So we're going to review the role of imaging in the context of this new updated diagnostic criteria. And I will give some insight into specific technique modifications that we do, and some scenarios where imaging can't answer the question, what those questions are. So updated diagnostic criteria has just been created. It only came out, I think, this summer. And the reason it was is due to overlap in NF2 and schwannomatosis. So because we know more about genetic testing, in addition to more about tumor biology, well, with respect to tumors that are indeed associated and not associated with NF2 and schwannomatosis. So this criteria, just like prior criteria, has a clinical criteria and genetic criteria. And the clinical has to be met first, followed by the genetic. And once you have genetic testing, we take that gene and we say gene-related schwannomatosis. So the new nomenclature, if NF2 gene ends up being found, it's NF2-related schwannomatosis, SMARCB1-related schwannomatosis, LZTR1-related, 22q, and then if the gene is not found or not tested for, it's not otherwise specified or elsewhere classified. So this is one of the first MRIs that I plan on showing. And this is a person that has, either hearing loss or tinnitus, and she ended up having high resolution MRI. And we see something expanding the internal auditory canal here. And this white is so it's here. And then when we give contrast, it lights up and takes up contrast. So that is a mass in the internal auditory canal. And there's a similar one on the other side. So a similar looking lesion here. So this person has bilateral vestibular schwannomas, and they've met the the clinical criteria for NF2, and actually gene analysis is not necessary. For this person, we had done high resolution, really thin section imaging, but if this person was to have thick section imaging and had bilateral vestibular schwannomas, they would still have NF2 because they met the clinical criteria. MRI is considered the best test for this reason, and it's highly diagnostically accurate. One might wonder, why not CT? It's pretty fast, happens in seconds. It's not as claustrophobic. You may not require contrast, but CT is not done for this indication, and there have been no papers with regards to CT and vestibular schwannoma since the 70s. And what we learned in the 70s was, if you didn't give contrast and did a CT, you would not be able to see about half the tumors. And if you gave contrast, you would still miss about 1 in 5. And they would all be less than 2 centimeters. So like a small tumor would not be seen by a CT. So we don't use CT for this purpose at all. It's MRI with contrast using thin section imaging. As the diagnostic criteria was modified, we know more information about genetic criteria in that genetic testing is positive in about 2/3 to almost 90%. And if a person has genetic analysis that's positive and a family history, they don't necessarily need imaging to make the diagnosis. Invariably, they will end up having some interaction with radiology at some point, but it's not necessary. So the first criteria for NF2 related schwannomatosis is bilateral or both sides vestibular schwannomas. Next is if there's an identical NF2 variant in at least 2 separate tumors in the body, or either two major or one major and 2 minor criteria. So I'll show you what the major criteria are. That's either 1 vestibular schwannoma, a first degree related, a relative other than a sibling with NF2 related schwannomatosis, 2 or more meningiomas, and an NF2 pathogenic variant in some other part of the body like blood or saliva. Minor criteria are different kinds of tumors within the central nervous system like ependymomas or peripheral nervous system like schwannomas, and juvenile cataracts, retinal hamartoma, epiretinal membranes, or meningiomas. So how can imaging play a part in this? So here is a person, and you can all see now, if we start with this one, this is the post-contrast sequence, so we see something lighting up on one side, not on the other side. So that is a unilateral or 1 vestibular schwannoma, and this imaging is able to establish 1 major criteria. Then the remainder of the brain shows something else here that we don't see on the other side. So this is outside the brain, but involving the lining of the brain or the meninges with this tail sign. So that's 1 meningioma, and then that's another. So 2 meningiomas are also a major criteria. And they can happen in up to 80% of people by the age of 70 in NF2. And this is an MRI of the neck. So for orientation purposes, that would be front, that would be back, that would be top of the head that we've not imaged, and this would be lower down. So these are the vertebral bodies, that's the spinal canal, and that's the back. So within the spinal cord here, there's some kind of a funny look about it that's not quite here or down here, and it's a little bit wider here than it is here. So what we would say as radiologists is there's a signal abnormality in the cervical spinal cord, and there's expansion. But based on just this sequence, we cannot say exactly what it is. It could be infection, inflammation, trauma, or tumor. So for that reason, you have to give contrast. And so now you see there's round-like things in the middle of the spinal cord around the central canal where there is ependymoma. So these are ependymomas. And again, you have to give contrast of the spine to be able to diagnose these. And that's another minor criteria. Similarly, so now we go lower down in the body. This is the thoracic spine, which is back here to here. And for orientation, this would be front, that's back, top of the head we have not imaged, and bottom. And these are the bones that make up your spine. And then this white is the cerebrospinal fluid or the liquid surrounding the spinal cord. And we see some stuff behind the spinal cord here. There's something here, and you wonder what it is. Is it real? So you give contrast, and among these, only one thing lights up, right? So that's something real. It's outside the spinal cord. Meanwhile, the rest of it is just movement from the fluid around the spinal cord. So this is a tumor, and it's a meningioma, and to diagnose it, one needs to give contrast. At the time of diagnosis, say if you wanted to follow it just to see if it's changed in size, you could get away without giving contrast. And if it looks completely unchanged, get another exam and get away without giving contrast. But at this point, to be able to diagnose it accurately, for that baseline exam, contrast is important. So here's another person, and I want you to look at a few things here. So this is lower in the back from here to here, like here. And for orientation, that's top, bottom, front, back. And so we have this lumpy, bumpy appearance here, and this thing here. So there are two things I want you to focus on. And we give contrast, and these lumpy bumpy things, they enhance or take up contrast. While this is down here and does not take up contrast. So contrast here is able to find tumors in the cauda equina nerve roots and characterize this abnormality as a cyst surrounding the nerve root. That's another reason we would give contrast in MRI. So these are small schwannomas, and they're able to fulfill additional minor criteria. So that's NF2. Now we'll talk about SMARCB1 related schwannomatosis, which was previously called schwannomatosis with SMARCB1 mutation. And here you need one tumor that's been taken out and confirmed pathologically as a schwannoma, and a mutation in an unaffected tissue like blood or saliva. So one of these along the foot and ankle would be removed, and it's either a schwannoma or a hybrid nerve sheath tumor, and blood or saliva. Or you take out two tumors and they have the same pathogenic variant. So for here, although imaging can help you find the location, plan the biopsy, it does not make the diagnosis. Ultimately, you need histology and genetic testing. The diagnostic criteria is identical for LZTR1, where instead of SMARCB1, the testing reveals a different gene. And imaging can help you find the tumor, find a symptomatic tumor that could be removed or biopsied. But genetic testing is key, and removing like histology of at least one tumor is necessary. It's a little bit different for 22q related schwannomatosis. Here, the person does not have to have, they have to meet several criteria. One, they can't have genetic testing that shows something else, like NF2, SMARCB1, or LZTR1. And then they have to have loss of heterozygosity of the same marker in two different tumors. So here, the part that's different is you need at least two tumors in the body that have to be removed, looked under. So MRI can help you find the location, plan the biopsy, but there's nothing about the imaging that would say that it's 22q related schwannomatosis. And then here, say you have two lesions that on imaging look like schwannomas. One of them is taken out and confirmed, but we either don't have genetic testing or we don't know which variant it is. So that would be called schwannomatosis, not otherwise specified or not elsewhere classified. And then we have mosaic schwannomatosis. Here again, we need at least two tumors. So MRI plays a role in helping you find the tumors, but it doesn't make the definitive diagnosis. I'll show you at least two scenarios where it's still tricky for radiologists and doctors taking care of this population. So here you have a young person, and because you've all seen many of these cases already, there's no enhancement in the internal auditory canal. So basically, this person does not have a vestibular schwannoma. We did really thin section imaging, the thinnest possible, none was found. But elsewhere in their body, for this person, they had many tumors within their spinal canal or somewhere else, and we don't have tissue. So basically, this person has many tumors. Some of them look like schwannomas, no vestibular schwannoma, and no tissue. What should we do there? If they don't want a biopsy, which some people don't, if it's not too bothersome or the biopsy is dangerous, you could just refer them for molecular genetic testing and follow them closely, because you don't want to lose them, but you cannot establish a diagnosis quite yet either. And key about imaging, I would say, if someone you want to follow or you want to get your own imaging followed, having it at the same site with a similar technique would be useful to make accurate comparisons. And now this is another unique situation, which we find tricky. And because you've seen so many of these scans already, there is one vestibular schwannoma here, the other side looks okay. So this is a young person, say they're 22, and they have one vestibular schwannoma. What do you do then? So that's our schwannoma. Data from Manchester suggests that if you were to look at all of these people and their genetic testing, about 1 in 5 may have a genetic mutation. So they say that in an unbiased cohort, where you've taken out people that were eventually found to have NF2 or had known NF2, about 20% or 1 of 5 will have a known genetic predisposition mutation. So it's a small population to begin with, but even then, a sizable minority will have a syndrome that was unknown previously. So Manchester, this paper suggests that if you have a young person that has one schwannoma, they should have genetic testing. If it's positive, then they would have a gene-related schwannomatosis based on that genetic testing. If it's negative, they should be seen at baseline at an NF center and then have some baseline imaging. The paper suggests doing high-resolution brain MRI to look for vestibular schwannomas on the other side and the entire spine from top to bottom with and without contrast. I would suggest if you see nothing there, whole body MRI is an interesting way that's non-invasive to look at the rest of the body to see if there's a tumor elsewhere. Then you would have one vestibular schwannoma plus another lesion that may be safer to biopsy to get a diagnosis. And then follow them closely. The paper suggests to the age of 40 because by then you should know it'll manifest itself one way or another. So now I'll share some more cases where I can show you what things imaging can do. So these are axial images, so going down in the thigh. And so here, this is front, that's back. And you can see a marker. So this person was able to put a marker in the MRI machine to where it hurts. And you can imagine in your mind's eye if we can see a tumor or not, and we're able to find a tumor. So using a marker at the site of pain is a really useful clue for us as radiologists and for technologists to note. And then if there is one tumor in that field of view, then we can say with reasonable confidence that this is indeed the one that's causing symptoms. Here's another example. So these are images of a foot, and we see this dot, and that is the marker on the top of the foot between the first and second toes in the midfoot, and that lesion is very painful, especially when putting on sneakers and tying shoelaces. So by MRI, we can find it, so we can detect it, and we can figure out what its anatomic extent is, i.e., we can map out for the surgeon whether it goes deeper into bone, tendon, size, how deep it is from the skin. Similarly, for a deeper lesion, this is a lesion in the armpit. So we see here, and all these different sequences. And every time an MRI is done, we do many different sequences. That's why it can take so long to perform. And that's that same person. And now we're looking at them sort of front back. And we can take that one image and lay out the anatomy so we can map out where the blood vessels are, where it is relative to muscle, to the chest, and to arm. So we help plan surgeries by figuring out what the anatomic extent of a lesion is. This is another person with a vestibular schwannoma here. After radiation, it looks much bigger here, but less is enhancing. And then many months later, even smaller portion is enhancing. So MRI plays a key part in looking at treatment response, whether it's favorable or failure of treatment. For the most part, you can just do measurements, like just measure using a ruler, or you can measure the entire volume using special tools. We can also, in tricky situations, so this is a real person that we have in our practice who has pretty severe pain in the front of their thigh. And the thigh in the front gets innervation from L2 through L4, basically these areas in the spine. And we see a problem above that area, and we see a problem below the area. So here the MRI is able to show us that although there are issues above and below in the area that's actually the most bothersome to the patient, we do not see something in their spine. So we look outside the spine. And this person was able to have CT-guided needle block. So they had anesthetist injected in the nerve that was bothering them. So we can use imaging to guide for injections and for biopsies. Then something that I've not talked about so far that much is we mostly looked at tumors so far, but we can also use imaging to look at the muscles. So if you look at these muscles, those are healthy muscles in the front of the thigh. And you can see that the ones in the back, these are the hamstrings, they look a little bit smaller and they have slightly brighter signal. Based on the group of muscles that's involved, we can suggest that there is denervation. So MRI can be used to find areas where muscles are denervated. And based on the distribution of where the muscles were denervated, we can look higher up to see whether there is a tumor or not. And so we were able to find this tumor, and this was removed, and this patient did ultimately feel better. Lastly, we can see denervation here also. So denervation is injury to the muscle after a peripheral nerve insult. And this person's muscles have become much smaller than the front of the arm and fatty replaced. So this person was having inability to move their fingers, finger extension problems, and the muscles are completely fatty replaced and atrophied. Basically, there's end organ damage. So the kind of surgery this person would require to regain function would be different. You would use tendons, tendon transfers to be able to move those fingers, not innervating the muscle because there's not much of the muscle remaining. So what can imaging do? We can help make the diagnosis, identify symptomatic lesions sometimes, establish baseline, so if there's going to be treatment, assess response to treatment, find out exactly what parts of the body the tumor is in to help plan a surgery, use imaging to either biopsy or perform an injection for symptom relief, and see how advanced or what the impact of a peripheral nerve tumor is on the skeletal muscle and how severely denervated it is. So those are the things we can do reasonably well. Now I'll show you some things where imaging is not perfect at. So here is a person that has a nerve tumor, and this tumor is located right here. So a little bit in the back of their arm, and it's contiguous with this nerve. So this is an ulnar nerve tumor. So we look at it, and based on all the information that we have, I can say with high confidence, this is a benign peripheral nerve tumor. I can say with some confidence that it's a schwannoma and not a neurofibroma, but that confidence is limited. Here's another person with a tumor in the back of their leg. And based on this appearance, I thought this would be a schwannoma. I was certain that this is going to be benign, but I thought it would be a schwannoma, and this was a neurofibroma. So if you just have MRI in front of you, there can be overlap in the way neurofibroma and schwannomas look. Not so much overlap between neurofibroma and malignant peripheral nerve sheath tumor, but benign tumors among themselves, they can look similar. This is another person whose legs, we see two tumors. So if you happen to see two tumors and say this person does not have a known history of a tumor syndrome, we would suggest, based on this, that there are two tumors, they look very similar, they're along the tibial nerve, this person probably has a tumor syndrome. We cannot say which tumor syndrome based on just some limited imaging of the legs, but we can suggest that there is a tumor syndrome. And this is another person. Again, they were kind enough to put a marker to tell us which tumor is bothering them. So that's this tumor right here. You see that? And this tumor looks pretty central to the nerve. That's a feature of neurofibroma, but you could be wrong. And we happen to capture another tumor higher up. So we were able to say this person probably has a peripheral nerve tumor syndrome. But if you only have imaging localized to a small body part, it can be very tricky. Sometimes we get patients in our practice that have cysts along their nerves, but these cysts are not where we expect them to be. So it can be hard to say that these are indeed cysts versus cystic schwannomas. And this person has 2 of them. So we may have to actually follow them and get more scans in the future. And then this is one of the toughest problems we have in our practice, where there are a lot of tumors and the patient has pretty intractable symptoms. So this person had sitting pain that radiated to their groin on both sides. And we can see tumors, these white things here, on both sides of the pelvis, going all the way around to the front. So when you have so many tumors and all along the same nerve, it can be very difficult by MRI alone to say which one tumor is the symptomatic lesion. So that's a real problem that imaging has not been able to solve yet. And then sometimes muscles, this looks like a person that maybe has denervation, but that was not the case. He actually ended up having cervical spine injury. So sometimes even muscles can look like they're being denervated. So imaging without a clinical history is not end all. It's not particularly useful. It has to be used as a tool to answer a question. So what things can't we do? We cannot reliably distinguish schwannomas from neurofibroma on imaging alone. If you have just one tumor in front of you, we cannot say that it is sporadic or syndrome related. If there are hundreds of lesions along the same nerve, we can't say which particular one tumor removal would lead to relief of symptoms. It can sometimes be difficult to separate a cystic schwannoma from perineural cyst, but that's an unusual scenario. And lastly, acute denervation in muscles can mimic other diseases. So their clinical history is extremely important. So what do we do in our practice? If we have a patient with schwannomatosis, they get seen first by the clinicians who do a thorough exam, skin exam, neurologic exam, eye exam, audiology testing, and then they get some baseline imaging. And then after baseline, if there are no symptoms, they get surveillance imaging, and the protocol can vary based on the tumor we're trying to follow. So if it's a vestibular schwannoma, we will do thin section imaging. And if it's not, if it's a meningioma alone, we may not do thin section imaging. We tend to always give contrast. And if there are symptoms, then we localize the imaging to where the symptoms are. If they're in the arm, we will only do an arm. That's about all I have for today. I had, I think, one more slide about cochlear implants, and I can talk about it if you guys like. If not, then. So we get a question about cochlear implants frequently. And the key there is to have the card they give you after surgery that tells you the make and model, because that gives us as radiologists information about what is their status, whether it's unsafe or conditional. Most tend to be conditional. And what that means is you can image them using a certain kind of magnet strength for a certain period of time, and that would lead to us modifying sequences so we can fit them in a smaller period of time. There's also wrapping involved that comes from the vendor, and that's really important. So the most important thing I would tell you is to keep that card, the make and model of the implant, so it can drive information for us. So now we can go back. You can always email me questions. I'm pretty good at getting back to them.
Okay, just really quick on with the cochlear implant, is that shadow always present? That's the cochlear implant, I'm assuming?
Yes, that's artifact from the implant. And so it will limit what we can see beside it here. But say you have a tumor over here that would still be seen pretty well.
Okay, cool.
Same issue with an ABI?
No.
No. With an auditory brainstem implant, would that be the same issue?
So any implant in the body will lead to susceptibility artifact. And that's true if you have a hip arthroplasty, metal from fracture fixation, anything that's ferromagnetic will lead to artifact on MRI. So if you have anything implanted in your body, having that card is critical, because every MR technologist and radiologist would look at the make and model of the prosthesis and go and research how to modify the protocol to be able to image safely. Because if we don't know, in my practice, I would not put someone in the magnet if I didn't know there was something inside them, because the last thing you want to do is harm.
Well, go back to that slide that you have from a Manchester study when you have one unilateral neurofibroma, yeah, and what you would do genetic versus multiple MRIs.
So I think my point here was to start with genetic, and if it's positive, then stop and go with whatever that information is.
And but if you were thinking about the diagnosis, and of course MRI is going to give you other information besides the gene. Do you know if there is any cost analysis between go to genetic test before going to all those MRIs?
That's really interesting that you say that. No, I don't. There's no cost analysis data as of yet. This is actually, I think this is maybe, this paper is 2 years old. And in all honesty, the group of people that will be isolated schwannoma in a young patient population, they only had people that were less than 25. And they found about 20% of those had genetic testing that was positive. So it's a very small population to begin with. Yes.
Can you clarify when you said, there is impossible from the MRI to distinguish between a schwannoma and a fibroma, but is that in the context of unknown diagnosis? Because of course we know that NF1 patients
Yes.
have neurofibromas and NF2. So be aware that if in your report you see a schwannoma and a neurofibromas, I would ask for clarifications, right?
So that's correct. People with NF1 should have neurofibromas. That's the hallmark tumor. People with NF2 and schwannomatosis should have schwannomas. I have seen people with NF1 have schwannoma on pathology. And I have seen people with NF2 have perineuroma and hybrid nerve sheath tumors. So I don't give a name. I just say benign peripheral nerve tumor, likely neurofibroma, if I know someone is with NF1. But my practice is also a sarcoma tertiary referral center. So we see just a mass. Someone comes in with a bump or a lump, no syndrome. So we keep an open mind and we just try and see if it needs a biopsy or needs close follow-up, or is it even a tumor at all?
Are there specific recommendations for people who have their implants or cochlea or an ABI when they do imaging? Do they have to know what's inside their body to give information? How do they know what was placed?
At the time of the surgery, they should give you a card, or there should be in we'll go as far back as looking into surgical notes to see what was placed. And in Epic, you can find, in our electronic medical record, you can find exactly what was placed. And then from there, you can get guidelines from the vendor, put this cochlear implant for such and such time duration, typically less than 30 minutes, and such specifications that they cannot exceed by MRI. So we'll modify the protocol based on that.
Does it ruin the quality of the imaging?
It's a cost benefit analysis, right? They have to get imaging, and it has to be diagnostic quality imaging. So we try and balance that with how long one goes in the scanner. I think it's diagnostic quality imaging. That's what you really want to know? Is it good enough? Yeah, it's good enough. Yeah, can it be fantastic? Yeah. Yeah, it's good enough.
Hi, sorry, I have another question. We know with NF2 related schwannomatosis, obviously, mostly are doing imaging of the brain with and without contrast and the spine. as a radiologist, do you suggest that full body imaging be done or extremity imaging be done? Because as we know, the tumors they might be rare in other parts of the body or rarer, but they can occur. And what are your thoughts on that?
I think it has to depend on the conversation with the team that's taking care of you. So in our NF center, if there's a group of people that'll take care of you, it's either a pediatric neuro-oncologist like Dr. Stedke or an adult neuro-oncologist like Dr. Romo or Blakely, and a discussion between them if there is a need for whole body MRI. There is a subset of people with schwannomatosis that we do whole body MRI on pretty routinely, less so for NF2 related schwannomatosis. Part of it had to do with like little we knew about schwannomatosis as a whole previously, and fear of malignancy, whether there is indeed malignant degeneration. And then in all honesty, schwannomas, neurofibromas they tend to be reliably easier to diagnose. Schwannomas can be more complex and heterogeneous on imaging.
My question is about contrast, the using of contrast. If you're doing 6-month yearly MRIs, the concern a few years ago I saw, and I'm just curious now what the stance is on the buildup of contrast in the body, things like that.
So again, it goes back to the thing that I said to you about doing no harm. So if there is, we meet every Friday morning and we decide together sometimes whether to give contrast or not to. And so if there is a tumor that say is going into the spinal canal and most of it is outside, we think it's growing, then we will ask for contrast to ensure we can really measure it very carefully and decide whether surgery needs to happen or not. If this is surveillance imaging and there are no symptoms, person is young, we could not give contrast. And if it looks identical on the 2 non-contrast sequences, we say, okay, next time also no contrast. If something changes, we'll bring them back. But yeah, there is much more awareness of giving contrast. Gadolinium is far safer than iodine-based contrast with respect to allergy, but this idea of buildup, especially in people that have repeated scans and people that have kidney failure, we're more cautious. But it's still it's a very safe contrast material.
And I think what Dr. Shivani said, Dr. Ahlawat said, the key is really that families, especially with young children, they're aware that if there are changes on imaging, that they might have to come back for the MRI. So if you, for example, have a very young child that needs anesthesia for an MRI, not doing the contrast and then having to go back and do the contrast, that's a problem. But if you have an older child that is able to tolerate the MRI without anesthesia, it might be less stressful for them to not have the contrast done if it is purely surveillance. And if there is a change, you ask them back. Yeah.
Questions? More questions?
Thank you, Dr. Ahlawat, for an excellent session. I think we had lots of great questions. I think if anybody can think of any other question after the session in the Hoover app, please submit the question or contact Dr. Ahlawat directly. And we do our best to get back to you guys. There's certainly lots of, as you saw, lots of new advancements coming up. So thank you for listening.
Thank you.